class.
All right, greetings. How's everyone doing?
Good.
I hope that exam treated you fairly well yesterday.
We hope so as well.
So welcome to Infectious Diseases. I'm biased, of course, but it's, I think, the coolest and the most fun specialty that we have in medicine. So you'll be learning an awful lot about infectious diseases and antibiotics over the next many weeks. So just a couple of announcements first. You may have noticed that I posted, I think it was 5 readings on Blackboard. So those will help you for the next few lectures, not necessarily for today really, but starting tomorrow we'll be going through basically Antibiotics 101, going through all the different antibiotic classes and doing the pharmacology again, but then getting more into drug-drug interactions, therapeutic uses, important side effects, etc. So I would say the first 2 readings that I posted, or as you go down the list, would be the most important one. One of them talks about principles of antibiotic therapy, and one of them also is a fairly comprehensive review of resistance and talking about resistance mechanisms, which we'll revisit from last semester. So really today will be principles of infectious diseases, then tomorrow we'll get into the antibiotics. We'll have several lectures where we just kind of go through all the different antibiotics and learn the details of those. I think it's important that you have a good, solid, I hope, basis in the different drugs, and that'll help you as we start getting into more specific disease state lectures, which will happen after next week. So, any questions before we start? And these again are just sort of interesting factoids of the day, so don't worry about being responsible for these first screens, just to give you something to read. So again, principles of infectious diseases. So today we will talk a little bit about the importance of infectious diseases from a society's point of view, from your point of view as future pharmacists. We'll also talk about really how you approach a patient who you think might be infected. So talking about signs, symptoms, laboratory markers that you would use to diagnose someone with an infection and also to monitor that patient after you've started therapy. We'll do a little bit of microbiology 101 as well to talk about some of the more important species that you'll need to know as we move forward throughout the rest of the semester. And then we'll talk a little bit at the end about sort of general principles of how we use antibiotics. And that will continue again next week. And so again, tomorrow we'll start going through bugs and drugs, or really bugs 101, and then we'll cap that off with a lecture next week about sort of the rational use of drugs and how we use drugs, hopefully in appropriate ways, and how you as pharmacists can help physicians and other providers help to use drugs appropriately. So you've seen this quote once before back in pharmacology. I like this quote because I think it reinforces the idea that the antibiotic era is relatively new, and so it wasn't all that long ago where if you came down with an infection, you basically were a goner, essentially, and so there was nothing much that we could really do. One of the articles that I posted talks about the fact that George Washington died of epiglottitis, and when he died of epiglottitis, the therapy that was used to try to cure him of his infection was, for the most part, bloodletting, which is basically taking repeated withdrawals of blood to cure toxins from the body. And so, as you would expect, bloodletting wasn't a very effective therapy to treat his epiglottitis. And so now recently we have the so-called antibiotic era, and so this kind of reinforces this quote, the idea that it was kind of viewed as magic and even black magic when we first had antibiotics, and we went from a situation where it was really an all or none phenomenon, either death or survival, to a situation where with antibiotics we could really help to cure patients, and in many cases have extremely big impacts on overall morbidity, mortality, and survival. So on the other hand, and we'll talk a lot about resistance over the next couple of months, even Fleming, so this was in Alexander Fleming's Nobel Prize lecture, even him early on noticed that antibiotic resistance could occur in the laboratory. So he noticed the development of resistance to penicillin shortly after discovering penicillin. And so, the previous slide, we had the wonder of the antibiotic era, and if you watch the news at all, you see constantly stories about outbreaks of resistant bacteria and infections and outbreaks caused by those bacteria that are, in many cases, resistant to everything that we have. And so we're sort of sliding towards, unfortunately, the post-antibiotic era, and we'll talk about that much more next week and going forward. So this shows, I think, one example of the impact of infectious diseases. And so this shows number of deaths annually in millions by a variety of different infectious diseases. And so respiratory infections, diarrheal diseases, HIV/AIDS, etc. And so as you see there on the right, annually we have nearly 60 million deaths that occur worldwide, and 15 million or so of those are caused by infectious diseases. And so infectious diseases still, despite the availability of treatments for things for which we once had no treatments, still cause a lot of death, morbidity, and mortality each year across the globe. And then this slide shows that it's even more important in developing nations. And so we in the United States are relatively spared from the impact of infectious diseases, whereas in developing nations, so over on the right there, you see that over half of all diseases are caused by communicable infectious diseases, whereas on the left, we deal much more with non-communicable diseases, things like heart disease, diseases sort of the modern world, whereas many other regions of the world where they don't have the infrastructure that we do, they have a much greater impact of infectious diseases on overall, again, morbidity, mortality, and survival. So other things that infectious diseases do, certainly they cause morbidity and mortality. Infectious diseases are also associated with certain other diseases. So as you probably have learned, H. pylori we now know is really an infectious disease for the most part. And so there are other examples of that where some have said that really all diseases, one way or the other, have some sort of infectious basis to them. That's not really been shown yet. But there are diseases such as heart disease that may have an infectious link to it, for instance. And so infections can cause other diseases, certainly. There are economic effects, historical impacts. There have been wars that have been decided by one side being struck by an epidemic of influenza, for instance, and so there have been societal impacts. There also are political implications as well, and so this next slide shows what I think is kind of an interesting story of the first ever incident of bioterrorism in the United States. And so this occurred in Oregon back in 1984. And so the individual on the left there was the leader of a religious organization, and he wanted to win a local election, basically. And he wanted his followers to help him win this local election in the Dalles, which is a city in Oregon. So in order to sort of sway the vote his way, this individual had his followers basically disseminate salmonella throughout the area of the Dalles to try to incapacitate everyone who was not one of his followers, basically. And so, for instance, this shows some fast food chain restaurants in the area of the Dalles, and so they would go into these restaurants, into the salad bars, and they would sort of spray salmonella in the salad bars. They also got salmonella into the water supply as well. So the whole idea was that on election day, if everyone but us is sick with salmonella, then we'll win the election, basically. So in the end, his plan was found out, and he was not successful, but as you see there, they caused quite a number of illnesses by having this incident, which again was the first incident ever in the US of bioterrorism. So that's sort of some of the reasons why infectious disease is important to us globally. Why is it important to you as future pharmacists? I think as you'll find, ID crosses many other specialties, so if you're on a cardiology API, you'll see patients with infectious disease all over the place, and so it crosses many other disciplines. It's also an area where you as a pharmacist in the end, with your expertise in infectious diseases, you can have a great impact on patients' health, morbidity, mortality, et cetera. And so really, as opposed to hypertension, where if you choose the wrong drug with someone who's newly diagnosed with hypertension, you're probably not going to kill that person, right? Whereas, again, infection is more of an all or none proposition. And so if you give the wrong antibiotic to someone, more than likely, not always, but more than likely, they're not going to survive. And so if you have that expertise to help people choose appropriate therapies, then you can have great impacts on your patient survivals. Also a very evolving field, especially nowadays with all of the resistance that we're seeing. And so having the knowledge to help in the face of these pathogens that are often untreatable is an important thing as well. A lot of public health implications as well, and so with these diseases having basically the ability to be communicated through other people in society, you're not only worried about your own patients in your hospital, but also the risks of them transmitting infections across the community as well. And then finally, pharmacists do play a major role in kind of taking care of antibiotics and ensuring their appropriate use. And more there are hospitals that have a dedicated ID pharmacist whose job it is basically to help physicians, help nurses, and to help them use appropriate drugs, use drugs wisely, use drugs when they should be used, and avoid their use when they're not necessary. And so a big role for pharmacists in many, especially hospital settings nowadays, is ensuring appropriate use and being good stewards of antibiotic use. So we'll start with a patient case, so just a sample case. So here you have CJ, 78-year-old male, admitted to the ER through Maine Medical Center, chief complaints of fever, cough, right-sided chest pain, shortness of breath, was in his usual state of health until 2 days prior to admission, and then his symptoms kind of got worse over time, so we thought it was time to finally go to the ER with his symptoms. States that he's been so ill that he has stayed in bed and not eaten for the last few days. So his past medical history includes COPD, joint disease, type 2 diabetes, which is diet controlled, AFib, and gastritis. Social history includes smoking for 25 years. You see his medications there, so prednisone, albuterol, APAP, warfarin, antacids, PRN. Allergies include an allergy of penicillin, which is described, or to penicillin, which is described as nausea as the reaction that occurs when exposed to penicillin. So you've done some physical assessment classes already, right? So do all these different acronyms mean anything to you at this point? Do you know what HEENT, for instance, means at this point? Okay. Are there any that don't make sense on this slide? Or have you learned all of these? So general ill-appearing man, you see the blood pressure, respiratory rate, heart rate there, temperature 39.5. He has no skin rashes, however he does have purulent rust-colored sputum, bilateral bronchi and rales, left lower lobe dullness when you auscultate the chest, regular rate and rhythm, normal range of bowel sounds, alert and oriented, etc. So those are some of the physical findings of this individual at this time. You see some labs here, so BUN of 35, which is elevated, a creatinine of 1.8, which is elevated. You see a white count there as well, plus the differential of the white count. We'll talk about that in a few minutes. Then you have a chest x-ray which was done, and so you show again left lower lobe consolidation consistent with pneumonia. And then from a microbiology point of view, you have a sputum gram stain which is pending, and you've taken both sputum and blood cultures which are also pending as well. So this often is really where you would first see a patient who presents who might be infected. And so the question becomes, how do you approach this patient? And so the first thing to figure out is this person actually infected? And there's many things that can look like infection but really aren't infection, and that comes into play when we want to talk about using, again, drugs when we need to, and avoiding inappropriate antibiotics, because there's many cases where you would maybe jump right to giving someone antibiotics where you could have held off on doing so. However, if you decide the person is infected, and this person is infected, as we'll see, you then start looking at what are the likely pathogens that might be causing infection in this person. And so based on the person's risk factors, their history, their exposures, what might be different pathogens that would be likely in this person. Then you face the issue of, do you need antibiotics? So still, even if someone's infected, you may not always need to give antibiotics for every infection that we see. However, if you decide to give antibiotics, which ones are the best ones for this person? And then finally, I think an important thing that we often ignore is once someone is successfully cured, they're on antibiotics, what do you do then? Do you keep them on antibiotics indefinitely? Do you remember to discontinue your antibiotics? Do you follow up, etc.? And we'll talk about that. So this really shows, and I think I've shown this slide to you once before, sort of the continuum of all the different ways that we use antibiotics. And so certainly there are cases where we use prophylactic antibiotics where you have someone who's not infected but you're wanting to prevent infection. So for instance, someone who's going in for a dental procedure that might have a risk for endocarditis would receive prophylactic antibiotics to prevent the development of endocarditis from that dental procedure. Then you have the time course where you have infection, and so you have someone who presents with symptoms, and so you have your empiric phase of therapy first. So at this case with CJ, we right now are in the empiric phase of therapy where we don't really know what this person has. We know they have pneumonia, or we think they have pneumonia, but we know nothing other than that really. And so at this point, really we're kind of guessing when it comes to our best drugs to use. So that would be the empiric phase of therapy. We'll talk about how you kind of balance covering every single known pathogen versus being a little bit more selective, which we try to do. Then you isolate your pathogen so you then know what this person actually has. So then you shift from empiric phase of therapy to the definitive phase of therapy where you can change your antibiotics depending on what your initial empiric phase was. Then you hopefully have resolution, and so sometimes, not often, you do have a need for suppressive therapy. So for instance, HIV patients who have certain opportunistic infections, they will end up on therapy for the rest of their lives against whatever that infection was. Not usually the case, but we do have instances where we have the need for suppressive therapy after we cure an acute infection. So I think it's important, again, to reiterate, and you'll hear me harp on this quite a bit, as will Dr. Kuhn, but we generally don't use antibiotics very well in this country, especially. And so this shows data on inappropriate antibiotic prescriptions. And so it's said that at least half of all antibiotic prescriptions that we see, especially in the community, are inappropriate and unnecessary. And so the consequences of that are we spend, of course, a lot of money on inappropriate drugs that we don't need to dispense, but more importantly, it just drives the current epidemic of resistance when we use these drugs when we don't need to be using them. You see a few examples of common situations where antibiotics are often given. One of the most important ones would be viral infections, and so has anyone had sort of a flu-like illness maybe this winter and gone over to health services, and hopefully, but I would not be surprised if they may have offered you some azithromycin, so giving you a little bit of a Z-Pack, right? So you probably didn't really need that Z-Pack, but again, we don't use antibiotics appropriately, and we just kind of have the knee-jerk reaction to give drugs, often in cases, as shown here, where we could avoid the use of those unnecessary drugs. So this talks a little bit about the chain of infection. And so for something to be an infectious agent, and there certainly are bacteria and other pathogens that aren't infectious, you need to have things like a reservoir of infection for that organism to live in. So we have certainly situations where we have animals as reservoirs of infection that then can be transmitted to humans. You then need to have a portal of exit from the reservoir, so a way for that pathogen to get out from its initial reservoir. You then need to have a mode of transmission, a portal of entry into the human host. You need to have a host, human or otherwise, that is susceptible to that infection. So really, those are all some of the things that play a role in whether something is infectious or not. And I think an important or sort of interesting factoid is that you have more bacterial cells in your bodies than you do have human cells, actually. And so with all of your normal flora and all the things that are colonizing you right now, you could say that you are all more bacteria than you are human in some respects. And so just sort of an interesting ecological issue, I suppose. So infectious agents, we'll talk about these again later. So really this semester, most of the diseases we'll talk about will be diseases that are caused by either viruses or bacteria. Remember again, fungus. So there's some of you who might refer to the plural of fungus as being fungi. Anyone? Yep. Some who might say fungi. So there's really, again, no right answer. But then you have your parasites. We won't really talk about prions or toxins too much here, but really, for this semester, most of what you'll be learning about and deciding what to treat will be bacteria, viruses, a little bit of fungi as well, or fungi. As far as infectious sources, so we do have certainly endogenous infections, so especially when we wipe out our own normal flora, we have the ability to allow things that are inside of our bodies that are ordinarily harmless to start overgrowing the normal flora and causing infections. And so again, another reason why we try to limit antibiotic use is because antibiotics destroy your normal flora and they cause imbalances, which leads to some of these endogenous infections. More commonly would be the exogenous infections that come from either waterborne sources, foodborne sources, airborne sources, or from fomites. I don't know if you've learned about fomites yet, but fomites would just be really inanimate objects that carry the potential to spread infection. One example being a stethoscope. And so stethoscopes are a great way to transmit infection from one person to another if they become colonized with bacteria. Nosocomial infections would be those that are acquired within a healthcare facility. Those become important because many of the pathogens that you see in healthcare environments, such as hospitals, become multi-drug resistant. And so if you get nosocomial infections, those are often harder to treat because, again, of resistance concerns. And then finally, you have opportunistic infections, such as infections in HIV-positive patients where they have that immunocompromised state and they are susceptible to pathogens that perhaps you or I would just be exposed to and would have no ill effects from, but if you have a weakened immune system, then you're susceptible to those opportunistic infections, basically. Then types of infections, so this becomes important when we're deciding on antibiotic therapy. So localized infections in general would be easier to treat, and so if someone has just a localized skin infection, that would be a much more easily treatable infection in general, versus if someone has that skin infection, the infectious agent enters the circulation, you become bacteremic, you now have a systemic infection. That typically is a more difficult infection to treat and causes more morbidity and mortality. As far as acute versus chronic, generally speaking, acute diseases are more difficult to treat as well, but we can certainly have chronic infections that can last for months, even with antibiotic therapy. Usually we're more in that acute phase of therapy, however, when it comes to infectious diseases. So any questions so far? Yes. So we have someone like CJ, and you're trying to evaluate whether this person is infected. Unfortunately, many of the signs and symptoms of infection are very nonspecific, and so you have things like rubor, dolor, calor, tumor, so redness, pain, warmth, and swelling. So those are the 4 cardinal signs of inflammation. Certainly, those are very common signs of infection, but they are also, unfortunately, signs of many other things as well. So rubor would be redness, dolor would be pain, calor would be warmth, and tumor would be swelling. Then you have functiolasa, which basically means loss of function. So maybe if you have a really bad skin and soft tissue infection, you might lose the mobility of your hand, perhaps. And so just loss of function is another common sign of infection. You have things like pus, exudates, some indirect signs. So there are diseases like endocarditis, for instance, that you wouldn't think would cause dermatologic manifestations, but they can cause things like skin rashes, splinter hemorrhages as well. So some of the cardinal signs of endocarditis, for example, are some of these dermatologic signs. So they're really indirect signs of another disease that's going on. We'll talk in a second about hyperthermia, hypothermia, hypertension, hypotension, gradient tachycardia. As I said, many of these signs are very nonspecific. So weakness, fatigue, malaise, weight loss. You may have had some of those symptoms when you were preparing for your therapeutics exam, perhaps. Perhaps, I hope not, but hopefully no nausea and vomiting or dehydration or headache. But very non-specific symptoms that make it hard to diagnose infection without going into a little bit further examination. And then leukocytosis, which we'll talk about, would be a little bit more of a specific symptom or a sign of infection, but again, not terribly predictive at first. So when you're talking about the sort of the progression of symptoms in an infected patient, I think it's important to know that you're often infectious before you know you are infected. And so, for instance, with influenza, if you come down with true influenza, you have been contagious for a couple of days before you start having your symptoms show. And so this sort of shows kind of the timeline where you have your infectious load and then you have your signs and symptoms. And so you sort of have this early prodromal phase, you have your acute signs and symptoms that start, those worsen over time. Hopefully with therapy, or even for things like the flu without therapy, for instance, you'll start having a decline phase of your signs and symptoms as your immune system clears the infection. Importantly as well, for many diseases, you're still infectious even when you're in this decline phase and when your symptoms have gone away as well. So it becomes important from a sort of a public health standpoint and making sure that we're preventing transmission of infection from one person to the next. So important vital signs then, and I would not on an exam ask you, this patient's heart rate is 58, are they bradycardic or not? But I think it's important as we go forward and start going through cases that you start to be able to recognize when some of these signs and symptoms are abnormal. I think heart rate and respiratory rate and blood pressure are a little bit less important when you're looking at someone who is infected, and many infections would not cause you to have an elevated heart rate or respiratory rate or even an elevated blood pressure. I think more importantly would be temperature, certainly, and we'll have lots of cases where you're going to be evaluating patients and seeing whether they are febrile or not. And so when it comes to temperature, there is actually no one clear-cut rule for what makes something a fever versus what makes something not a fever, and so different sources will have different guidelines for what truly is a fever. But a good rule of thumb is that if someone's oral temperature is above 38.8 or 100 Fahrenheit, then that would be indicative of a clinical, by definition, fever. So I think really that would be the most important of these vital signs for you to kind of get an appreciation for. Again, I'm not going to ask you to know on an exam what these values are, but you'll start to kind of learn them as we go through more and more patient cases. So a little bit more about fever. So it's considered to be certainly the cardinal sign of infection, and many patients describe fever as sort of the first thing that they noticed that made them think they had an infectious process going on. However, as you see there, especially in elderly patients, they often can't manifest a fever, and so less reliable to diagnose infection in elderly patients. But even in other patients as well, fever can often be absent when you would think it should be. Also, importantly, fever definitely, while it is the cardinal sign of infection, it's not in and of itself a great diagnostic sign to conclusively say that one has infection. And so you see there some of the many examples of other conditions that can make someone febrile. And then unfortunately, drugs can have an effect as well. And so certainly, it's our case with CJ, he's on APAP. I didn't tell you how much he's taking of acetaminophen, but if he's a chronic user of acetaminophen, then that can certainly mask any fever that he may have manifested otherwise. So really all of these agents that you take when you have a fever can complicate the diagnosis of infection because they would make your fevers not manifest. Importantly too, there are drugs that can cause so-called drug fevers, and so these are some of the very common examples of drugs that can in and of themselves give a patient a fever and again make you think falsely that someone may have an infection. Okay. So this is a diagram of the immune system, which you learned, I guess, last year, right? So everyone remember the different phases of the immune system. So on the right, you have the adaptive immunity system, and so you have your B cells, your T cells, so your antibody-mediated immune system. On the left, you have your innate immunity, so you have your things like your macrophages and your natural killer cells, et cetera. And so when we do a white count with differential, which we'll show on the next slide, we're measuring not only your white count to see if you have leukocytosis, which is a more reliable sign of infection, we're also trying to break down the different subtypes. So we're measuring these different types of your white count differential. And so this shows what is measured when you see a WC with diff or a WC with differential. And so on the left, you have your agranulocytes, so your monocytes, which become later on when they mature, become macrophages. Then you have your B cells and your T cells, so your B lymphocytes and your T lymphocytes, so that adaptive part of the immune system. And then on the right, you have your granulocytes, so your basophils, eosinophils, and neutrophils. And so neutrophils being the most important component of your white blood cell count. An important distinction would be your bands versus your segs, or your segmented neutrophils. And so segmented neutrophils, which are shown here on the right, are mature neutrophils. And so bands, on the other hand, are immature neutrophils. And so as we'll see on the next slide, if you start to see an elevation in your your immature neutrophils, that is indicating that something is going on from an infectious process. And so when you see a white blood cell count differential, as we saw with CJ, you'll see numeric breakdowns of the percentages of all these different subtypes and what part of their white blood cell count they make up, basically. So here's an example. So normal white count is 4.4 to 11.1. Again, there's some variation depending on the resources that you use, but that's a good rule of thumb. So leukocytosis would be just a white count over 11, basically. And so that would indicate your white count is elevated. Again, not conclusive evidence of an infection, but an important sign of infection. And then you have what's called a left shift or a shift to the left. And so that basically means that you have an elevated proportion of those immature neutrophils or those bands. You'll also hear this called a bandemia, so elevation of bands in the blood. And so here's the typical way that your white count would be described. So you have, for instance, 3 bands, 60 segs, so your mature neutrophils, then you have 20 lymphs, 5 monos, 1 eosinophil, and no basophils. Then you shift later, so you repeat the white count in this patient, and now you suddenly have 10 bands. So you've gone from an elevation, or you've had an elevation of those band cells, and so that would be called a so-called shift to the left, or a left shift, which indicates that your bone marrow is basically pumping out neutrophils, and so you're seeing more of those immature neutrophils that are being produced, so indicating that you're fighting off infection. And it's called a shift to the left because historically when white cell counts were written down, bands were always on the left-hand side of the form, and so you'd have a shift of numbers towards that left side, basically. So again, not a conclusive sign of infection, but when someone has leukocytosis, they also have a left shift, they have a fever, you're starting to put together the pieces that something may be going on from an infectious nature. And so, so what signs and symptoms does CJ manifest right now that would make you think he might be infected? Just shout it out.
Elevated white blood cells.
So he has an elevated white count, right? High temperatures. He's febrile, right? So his creatinine is high. Do you think that indicates that he's infected, per se? So probably not an indication of infection. It is an important thing that we'll talk about, though, when you're deciding on therapy, though. What else? Respiratory rate is high, right? Heart rate's high. Should you have left lower lobe consolidation in your lungs if you're just walking around on a daily basis? No, so that's certainly a problem. Said he's febrile, has a white count. What's that?
His chest X-ray.
Yeah, his chest X-ray. So if you take a chest X-ray, you shouldn't be seeing opacities and evidence of infiltrates and things like that. How about purulent sputum? Does that seem normal to you?
Sure.
So certainly that would not be normal. The color of the sputum is an indication as well. So there are certain organisms, as we'll learn when we talk about pneumonia, that can make your sputum turn different colors, for instance. And so, yeah, so those would be, I think, all of the different signs and symptoms of infection in this particular patient. Did we miss anything? All right, so now we've entered that empiric phase of therapy. So we're pretty sure this person's infected based on their signs and symptoms, their chest X-ray certainly, and when you're evaluating someone with pneumonia, as we'll talk about, a chest X-ray is considered to be the most reliable way of diagnosing pneumonia. So we've used the appropriate diagnostic method, and that indicates he has pneumonia. We're waiting on our microbiology results, and so really at this point, if we're going to choose therapy, it's going to be somewhat of a guessing game to choose the right antibiotics. So that said, what should you be considering when you're choosing empiric therapy? So age certainly is important. Age from the standpoint that especially older adults are going to be more prone to certain infections and maybe exposures to certain pathogens. Age becomes important because there's certain drugs we have to be careful about with older patients who might have things like elevated creatinine and so renal dysfunction. You want to look for portals of entry, and so does this patient have an open wound perhaps that may have indicated the way that bacteria introduced into him? I think an important point is that we think this person has pneumonia. That doesn't mean that they couldn't also have a UTI, they couldn't have bacteremia, which again becomes a more serious infection. And so you have to be open when you're examining patients to seeing other things perhaps that might be going on. So then becomes the site of infection. And so we think this person has pneumonia, so we're looking at his lungs. And so there are certain drugs, as you'll learn, that may get really great concentrations in the lung and become good therapies for pneumonia. And there are certain drugs that don't get very good lung concentrations, so you wouldn't use them in someone who has pneumonia. Comorbidities and predisposing conditions become important both from the standpoint of kind of narrowing down your pathogen list. And so patients with, for instance, COPD in this situation, they might have certain pathogens that a normal, healthy person wouldn't be exposed to or wouldn't have a risk for causing infection. Comorbidities also become important because sometimes they dictate the therapies that we use. And in fact, in pneumonia, we use different drugs depending on the presence of different comorbidities like COPD, asthma, cancer, etc. Immune status is very important, certainly, and so you have again, your patients with HIV, where the spectrum of pathogens that could be causing pneumonia in a patient with advanced AIDS might be very, very different from that of someone who's a normal, healthy individual. I think importantly too, systemic corticosteroids, so this person's on prednisone, right? I didn't tell you how long he's been on prednisone or what dose he's getting, but it doesn't take an awful lot of long-term prednisone use to make someone basically functionally immunosuppressed, and again, open up the causative pathogens into a broader list of pathogens that might be causing pneumonia in someone like him. And then antibiotic exposure is always an extremely important one from the standpoint of resistance, and so we want to know if patients have been on antibiotics recently, because that often can suddenly change our focus to have to deal with maybe empirically covering resistant pathogens, whereas we wouldn't if someone had had previous antibiotic exposure. What is important as far as the timeline of previous antibiotic exposure, that depends on the infection, but for instance, in pneumonia, if you've been exposed to antibiotics within the previous 30 days, that's considered to be important. There are other infections for which the time frame might be different, but we don't care if someone received antibiotics 3 years ago, because that probably wouldn't affect what's going on right now. But if they recently finished a course of a Z-Pack or something like that, then that might, in this patient, really change what we do as part of that empiric phase of therapy. So other situations, so allergies, of course, we don't want to give patients drugs to which they are allergic. On your exams, I don't know if you've had this so far with your psychopharmacotherapy exams, but allergy is a big thing in infectious diseases, and the most common causes of drug-related allergic reactions are antibiotics. And so advice when it comes to your upcoming exams, if I give you a patient case and I tell you that so-and-so is allergic to whatever, you probably don't want to use that drug and think you're going to get full credit on that question. So always look for allergies when you're looking through patient cases. That said, the nature of the allergy becomes important. So anyone think that this person, CJ, has a true allergy to penicillin? So no, not really. He just has intolerance. And so, we would easily give him penicillin and really not feel too bad about doing so. But as we'll see, and we'll talk about the different types of allergy, there are certainly signs of allergy that become much more of a red flag that you would want to avoid the use of those drugs. Kinetic changes, and so we mentioned creatinine clearance. So this person has an elevated creatinine, they have an elevated BUN, and so they appear to have some form of renal impairment just based on those two findings alone. So there are certain drugs that we'd want to be a little bit more careful about when it comes to either choosing to use them, or if we do use them, perhaps having to use different dosing methods because of the dangers of accumulation in someone who has apparently renal impairment. Hepatic impairment as well is an important thing. Weight becomes important because the doses of drugs that are approved are based on the ideal 70 kilo person, which we don't have a ton of in the United States on an overall scale. So you want to always be cognizant that you're accounting for wide variations in weight when you're giving your drugs. Pregnancy and lactation become important, and there's certain antibiotics that are absolutely contraindicated in patients who are either pregnant or lactating. And then epidemiologic factors as well, which is part of the fun of ID, I think, in that if this person had been to Western Africa recently, might we start thinking about Ebola? Or if he had been to the Soviet Union, would that maybe mean that he has extremely resistant tuberculosis? And so sort of the travel history, exposures, place of residence thing becomes important, because you can have some unique pathogens that you wouldn't see maybe in Maine, but if someone was living in a more exotic location, you might start changing the ways that you would do your empiric therapy, because you might want to treat things that are a little bit more unique. So other drug factors, so you certainly always want to give something that's going to cover the pathogens that you're worried about, otherwise you're just giving a placebo essentially. And so we'll talk about kind of choosing the likely pathogens and then choosing a drug that covers those pathogens. We'll talk a lot about MIC data and using MIC data, resistance profiles, that sort of thing, either on a local level or on a patient-specific level. So you want to choose drugs to which you think something's going to be susceptible if you're going to roll the dice and avoid resistance. Evidence of efficacy, of course. So if you have published treatment guidelines, which we'll talk about, that show that drug X is the preferred drug, has the largest number of randomized controlled trials supporting its effectiveness in pneumonia, then that becomes probably a better drug to use versus something that has maybe maybe it's a new drug and has just a single observational study to support its use. And so we want to use basically evidence-based medicine when we can. I mentioned a little bit about pharmacokinetic factors. So again, using drugs that get to the site of infection and get good concentrations at the site of infection. Certainly safety and toxicity is important, and also drug interactions as well, and so trying to avoid using drugs where someone may have a predisposition for a certain side effect. Of course, adherence is important, and so if we can use oral drugs, we want to prefer using oral drugs versus IV drugs or IM drugs. Number of doses per day becomes important, so we want to try to ensure adherence by using, for instance, daily dosing if we can do so. And then finally, cost. And I would say that when it comes to infectious diseases, we tend to worry a little bit less about cost, because if I give you the cheapest antibiotic that I can find that costs maybe $2, but I'm giving you the wrong drug, then the costs of you failing that therapy, probably becoming hospitalized, maybe having an ICU stay, all of that cost really far outweighs anything when it comes to drug costs for the most part. So we don't worry too much about cost, and I would say it's kind of the last thing you would worry about. Except, of course, as you'll learn, as some of you may know, our new hepatitis drugs have kind of changed the landscape, and so those are extremely, extremely expensive, and so that might be a different story. But for most antibiotics, really, cost becomes a low-level concern. So, getting back to CJ, so what risk factors for infection does CJ have?
Yep.
So COPD, certainly, can predispose to having pneumonia.
It's on steroids.
So he's on steroids. Again, I didn't list the dose or the duration, but if he's a COPD patient, it's likely he's been on long-term, maybe high-dose prednisone, and so that could make him basically functionally, again, immunocompromised. His age, yeah, so he's older, I guess, right? So that puts him at risk, certainly, for infection in general. He's a smoker. That also puts him at risk for pneumonia as well. Yeah, so all those are all good things that could have put him at risk for infection. We don't know anything about his travel history or where he works, that sort of thing, but we want to ask him about that. So when you're deciding on empiric therapy for this guy, what do you think would be important things to kind of keep in mind? I think age would be one, and there are certain, and pneumonia is one example where the treatment that you would use empirically differs depending on the age and depending on the likely pathogens that might be infecting someone.
Renal function.
So renal function is a big one in this person, so this person does seem to have some evidence of renal dysfunction, so there's certain drugs that we probably just would want to steer clear away from, or that we might want to look at using reduced doses as well. Certainly you want to use something that's going to get good lung concentrations, right? So all of those PK factors as well. We'd want to avoid things that are going to interact with the drugs he's on. He's on some drugs that are fairly notable drugs when it comes to drug-drug interactions, so we want to be careful when it comes to that, of course. And then what else would you want to know about this person before you're going to give empiric therapy? Anything? I think for me the two big ones would be, has he been anywhere exotic, or has he had workplace exposures that would make something, a pathogen a likely cause of his pneumonia that I wouldn't have otherwise thought of? And the other big one would be, has he received antibiotics recently, because we don't know that. And so that would change what you might give this person as empiric therapy if he's had a recent course of a Z-Pak, for instance, or some other antibiotics as well. All right, so any questions about kind of the approach when you're physically assessing a patient?
Well, his history of having had pneumonia before also be one of the questions to ask him.
So would you want to ask him if he's had pneumonia before? Yeah, that would be a fair one. Why do you want to ask that in particular?
Probably to figure out what kind of antibiotic he was on.
Right, so this is that's a good point. He's an older person, he has chronic COPD, he may have had repeated respiratory tract infections, so that would then give you maybe more of a clue that he's received antibiotics. It might be something too because, if he's having repeated cases of pneumonia, are there things that we could perhaps do to help kind of stop that? So has he received vaccinations, for instance, that would help him to stop having repeated cases of pneumonia if he's having them? So yeah, that'd be a fair question, certainly. Any other questions? So again, we're in this empiric phase of therapy. We're trying to kind of guess at what we want to cover. So this person has pneumonia. So do we care about empirically covering E. coli? Probably not, because E. coli is a fairly uncommon cause of pneumonia. And so this sort of shows some of the anatomical relationship between microbes and the diseases that they cause. And so as you see there for pneumonia, this guy we think has community-acquired pneumonia. He came, we think, just from his house, basically. So he has CAP or community-acquired pneumonia. And so really, if I were a betting man, I would bet that his infection is caused by strep pneumo, because that's far and away the most common cause of pneumonia. And so, again, if you're choosing your empiric therapy and you're not covering strep pneumo for this person, you're really doing him a major disservice. And so you sort of use lists like this to kind of figure out, empirically speaking, what you want to provide empiric coverage for and what you are not so concerned about. So we don't care about covering E. coli, certainly, but we definitely want to cover strep pneumo, for instance. And so this becomes an important part of choosing an appropriate empiric therapy that doesn't have big holes in its coverage. And then finally, from a diagnosis point of view, we're waiting on samples, right? So we're waiting on a gram stain, we're also waiting on a culture. This sort of shows the timeline of the diagnostic process and receiving samples, running those samples by microbiologists, having them analyze the data. I think really, though, the important thing on this slide and the key thing to remember is that it's very important, if you can, to take your culture results, or to take your specimens rather, before you start someone on antibiotic therapy. And in almost all cases, you can afford to wait an hour or two to ensure that you get a good blood culture or a good sputum culture. And no one with pneumonia, or very few with pneumonia, are going to die if you wait those couple of hours to get a good sample. And so if you give antibiotics and then take your blood cultures, your sputum samples, etc., the yield of those cultures becomes much poorer, even with just a single dose of therapy. And so the good rule of thumb is that we always want to try to get our specimens before we start antibiotics. There are some examples of diseases where you can't wait, but those are fairly few and far between, as far as diseases like meningitis, for example, where you have to get antibiotics going as quickly as you possibly can. I won't talk about this too much today, but we'll talk a little bit about this next week in patient assessment. But we have our old tried and true methods of diagnosing infection, of culture, doing MIC testing. More and more these days, though, there are much more sophisticated ways of diagnosing infection. Compared to cultures, they tend to be more accurate. They also tend to be much more rapid. And so, as we'll talk about, the whole process from day one, taking cultures to getting your final culture results, takes 2 or 3 days, whereas we now have many of these PCR-based and other types of more sophisticated testing that can give you diagnostic results basically within minutes. So you think, well, why don't we just always use those? And there's a couple of problems with these types of testing. They are costly, as you would guess, whereas culture and the traditional method of doing testing is very cheap. And also, especially in our developing nations, we don't often have the availability of these rapid diagnostic assays. So I think we're definitely moving towards more use of these types of testing, but we're not as all the way there yet. So, ready for Microbiology 101? How many took microbiology here? So a lot of you, I guess, maybe half or so of you? Okay. So my goal is not to make you microbiology experts, certainly, but we'll go through sort of some of the basics, and especially you want to start kind of learning some of the more important bacterial species, and we'll talk about the more important ones that you'll be seeing over and over and over again. So before too long, you should know all the ins and outs of Staph aureus, for instance. So we're going to talk about Staph aureus over and over and over again. So anyway, so when you're classifying bacteria, as you know, we have gram staining first, so we'll talk a little bit about that. Then you have morphology, you have the distinction between aerobes and anaerobes. Aerobes definitely are much more common causes of infection. You have other growth requirements that we'll talk about, and then finally a little bit about biochemical testing. So just as a reminder, so you have your gram-positive bacteria on the left and your gram-negative bacteria on the right. So the distinction would be that the cell wall in gram-positive bacteria is much thicker than it is in a gram-negative bacterium. And so kind of that light blue area there is the cell wall. So a really thin cell wall in a gram-negative and a much thicker cell wall in a gram-positive. The other distinction would be that the cell wall in a gram-positive is sort of the outer layer of the organism, whereas in a gram-negative pathogen, you have this outer cell membrane, which becomes important, as we'll see later. So you have your gram-positives versus your gram-negatives. And so some of you maybe not too recently, I'm sure, have done gram staining. Maybe not if you took microbiology here, but this sort of shows the procedure for doing gram staining. And so you have on the left your gram-positive, on the right your gram-negative pathogen. So you first apply crystal violet, which kind of gets stuck in the cell wall. Then you give iodine, which helps that which helps the crystal violet to kind of stick in the cell wall. With gram-positives, they have that much thicker cell wall, so the iodine and the crystal violet really have much more of an area to kind of get stuck in, if you will. So then you decolorize with alcohol, and so the gram-negative with the much thinner cell wall with less cell wall for the crystal violet to stick into, the crystal violet all kind of gets washed away, whereas with the gram-positive, you have the crystal violet that stays there. Then you do your counter stain, so your safranin. So safranin is blocked by the crystal violet, so your gram-positive retains that violet color, and then your gram-negative becomes the red color. So on a microscope slide, if you recall, you'll see purple cells, red cells for gram-positive, gram-negative, respectively. Then you have morphology, so you have your spheres or your cocci. Cocci tend to be more important when it comes to gram-positives, and so the clinical organisms that we worry about from a gram-positive point of view are more likely to be cocci. Then you have your bacilli, which are more commonly gram-negative, so the important clinical pathogens that are gram-negative tend to be more of the bacilli. And then you have your pleomorphic cells, or your coccobacilli, so your kind of football-shaped organisms basically there in the middle, which are much less common clinically speaking. So this is a little small, and I can actually post a larger PDF version of this, which I will do to Blackboard, but this is really all the pathogens that we're going to talk about over the next few minutes. Now, do I want you to know all these pathogens? Definitely not. So I'll highlight some of the more important ones, and in fact there are ones on here that we really won't talk about too much whatsoever. So on the left you have your cocci, so your anaerobic and your aerobic cocci. And on the right, you have your bacilli, so your anaerobic and your aerobic bacilli. So again, cocci we worry much more about when it comes to gram-positives, and bacilli is the opposite. So first, when it comes to kind of narrowing down into a part of that large diagram, we have our gram-positive cocci. And so some of these different tests might ring a bell from your microbiology days. I'm not going to talk about the specifics, nor do I want you to know what a catalase test means, but you have a large distinction between your catalase negative versus your catalase positive aerobic gram-positive cocci. So on the right here you have your staphylococci. Then you do further testing, so a coagulase test, which becomes an important distinction. So a very important distinction becomes coag-negative staph, which includes Staph epidermidis as the most important pathogen. Then you have coagulase-positive staph, which is Staph aureus. And so that becomes a very important distinction that you'll see on microbiology reports, where you'll get a report saying this person has coag-negative staph. And so you know right away that that is not Staph aureus. And so Staph epidermidis compared to Staph aureus causes much more severe infections, tends to be more resistant than Staph epidermidis. And so if you had your choice, you'd much rather have an infection caused by Staph epidermidis versus Staph aureus. And Staph aureus, as we'll talk about, you have the ugly specter of MRSA as well, especially more and more nowadays. And so this becomes an important distinction as far as this kind of arm of that gram-positive cocci illustration, basically. Staph hemolyticus and Staph saprophyticus, much less common causes of infection, and you probably won't see those too often in the remaining disease-specific lectures. So then you have your catalase negative gram-positive cocci, and again, I'm not going to ask you to be responsible for knowing the different biochemical tests, but these really include all of your streptococci, and so you have a variety of different streptococci, just sort of highlighting some of them. And so group B strep over here on the left, strep A galactiae, that's an important pathogen, especially in pregnant patients and also in newborns who contract group B strep during the process of birth. So we'll talk about that in a couple of different disease states. Then you have your group A strep, so your Streptococcus pyogenes over here on the a little bit on the right there. So an important cause of respiratory infections, that would be the cause of strep throat, would be group A strep or strep pyogenes. Another big one would be Streptococcus pneumoniae, so you're going to see that in many, many different infections. So causes pneumonia, certainly, as we talked about today, causes meningitis, causes otitis media, causes endocarditis. So Streptococcus pneumoniae is something that you'll become very familiar with. Also a pathogen that has a fair amount of resistance nowadays, so that becomes a complicating thing when you're trying to treat strep pneumonia. So then on the right you have, I would say the next most important one would be your enterococci. So the enterococci were renamed from streptococci, but they are related to streptococci. So we have E. faecium and E. faecalis, and so we talked a little bit about those last semester. Those pathogens are thankfully pathogens that don't have a lot of potential to cause infection, so they don't tend to cause the serious infections that, say, Staph aureus would cause. They are important, though, from the standpoint of resistance, and so there are some resistance concerns that we'll talk about when it comes to especially vancomycin resistance in enterococci, which are difficult pathogens to treat. So any questions? Am I going too fast? So I'm just trying to highlight some of the more important ones that you'll be learning about. Yes?
What was the first one that you mentioned about pregnancy?
So that would be group B strep, or strep A galactiae right there. So now you have, so those are your cocci really, and I would say that from an anaerobic point of view, I've never seen this pathogen ever in my entire career, so I think it's safe to say you won't need to know the name of that pathogen. So shifting to the bacilli, so again, from an aerobic point of view, we certainly worry more about gram-negative bacilli than we do gram-positive bacilli. Before we get into the aerobic kind of wing of this, we'll talk about the anaerobes a little bit. So when it comes to anaerobes, really the big bad anaerobe that we worry about is that first one, so Bacteroides species, and especially Bacteroides fragilis. So Bacteroides fragilis has a lot of resistance compared to other anaerobes, more difficult to treat, and so that's sort of the big bad anaerobe that we worry about, and we'll talk about the other anaerobes a little bit later. So shifting to the aerobes, really you have the differentiation based on lactose non-fermenters, lactose fermenters. Again, don't worry about the specifics of that. But one thing I want to point out is you have this rather large family of the Enterobacteriaceae, so your enteric bacteria that live generally in our GI systems. So the most important ones there would be E. coli and Klebsiella, which together make up well over 3/4 of all the infections that would be caused by this big family of the Enterobacteriaceae. So you'll be seeing E. coli and Klebsiella quite a bit. They cause, again, many different types of infections, kind of like strep pneumo. So there are other Enterobacteriaceae listed here as well. Again, those are two of the big ones, would be E. coli and Klebsiella. Some of you may have noticed over the last week or so there have been reports on the news about the outbreaks related to endoscopes. Has anyone seen that out in LA? So the patients, hundreds of patients were infected by what's called CRE. So CRE would be carbapenem-resistant Enterobacteriaceae. And so these pathogens, unfortunately, nowadays are more and more associated with resistance and really multi-drug resistance. So we'll talk about CRE quite a bit, but CRE is problematic because we essentially have nothing that effectively treats it. So that explains in part why those patients that were in that recent outbreak had such severe illness, and many of them, or at least a handful of them, died. Let's see, some other gram-negative bacilli over on the left there in that box would be, I would say, not quite as important as your Enterobacteriaceae. We're not going to really talk about H. pylori too much this semester. You'll learn that when you talk about peptic ulcer disease next year. Haemophilus species would be an important cause of respiratory infections, fairly easy pathogen to treat, however. We'll talk about Legionella. So Legionella is one of the atypical causes of pneumonia, so we'll talk about that probably, I think, next week. But some of these pathogens, like Bordetella pertussis, we won't really be talking too much about. Brucella, Francisella, we won't talk about those really at all that I can think of. So not too much of interest really in this box here. And then finally, I would say, you might remember the space organisms. And so again, Pseudomonas is really, from an aerobic point of view, just like Bacteroides is our big bad anaerobe. Pseudomonas is our big bad aerobic gram-negative bacillus. So Pseudomonas is the most notorious, I would say, pathogen from the standpoint of having multi-drug resistance. And so the space pathogens, which we'll talk about, include a list of a list of bugs, of which Pseudomonas is one member. So these isolates over here on the right, things like Pseudomonas, tend to be nosocomial pathogens, highly resistant, fairly difficult to treat. So any questions on that? And I guess I went through this already. So again, I would say the Enterobacteriaceae and E. coli and Klebsiella would definitely be pathogens that you should start to learn. We'll talk about those quite a bit in many different disease states. And then again, the distinction between those and Pseudomonas and its related pathogens that are, and really all of these nowadays are becoming more and more resistant. So it used to be the fact that Pseudomonas was always resistant and E. coli was really never resistant, but now we have things like CRE, which is in the news, which are, again, resistant to everything. And so unfortunately, really across the board, we're not seeing very many pathogens anymore that don't have at least some amount of resistance that's emerging nowadays. So anaerobes, just briefly about the anaerobes. So when we're talking about anaerobes, and again, on the whole, I would say you're going to be learning much more about aerobic infections compared to anaerobic infections, but there are certainly some important anaerobic infections. And so when we talk about anaerobes, we usually make an important distinction, which is above the diaphragm anaerobes versus below the diaphragm anaerobes. And so above the diaphragm anaerobes include Peptococcus, Peptostreptococcus, Prevotella are some of the more important ones. So these are ones that are your oral anaerobes that we all have living in our gingival systems. These pathogens are fairly easy to treat. There are many, many, many drugs that cover or have activity against your oral anaerobes. And so it's almost a rarity to have a drug that lacks coverage of oral anaerobes. On the other hand, the below the diaphragm anaerobes that live in your GI tract tend to be more serious, also tend to be bugs that have more resistance concerns associated with them. So the big one, as I said, would be Bacteroides species, and the most important one there would be Bacteroides fragilis. So a highly resistant pathogen in some cases that becomes more difficult to treat. So these are easy up here. These are not so easy to treat down below the diaphragm. So revisiting CJ, so we have his gram stain results back now. So you're going to always get your gram stain results before you get your culture results back. Gram staining takes 20 minutes to do basically. Doesn't require incubation of your sample. So gram stain results typically will come back the same day that you retrieve your sample. So we have our gram stain results. Sputum has 4+ gram-positive diplococci. The 4+ is an indication of the number of organisms. So 4+ means he has a lot of these gram-positive diplococci growing in his sputum. So the most likely organism that is causing CJ's pneumonia would be So anyone want to venture for Klebsiella pneumoniae? So that would be gram-positive or gram-negative?
Negative.
Gram-negative, it would be a bacillus as well, right? So that's not correct. Neisseria gonorrhea, actually I forgot to talk about Neisseria gonorrhea. Gram-negative, it is a diplococcus in some respects, or in some cases, but it's more of a gram-negative. Staphylococcus, so why didn't you say Staphylococcus aureus, those of you who said Streptococcus pneumoniae? So Staph aureus would be gram-positive, right?
Mm-hmm.
So staph would grow in clusters. So staph is clusters of grapes, basically, that you would see on a microscope slide. So that's the differentiation between Streptococcus pneumoniae and Staph aureus. So yeah, the answer to this would be D, Streptococcus pneumoniae. My pod is going to go back just for 1 minute. So I forgot some of although I mentioned that gram-negatives, with cocci, we don't worry too much about gram-negatives. These are a few important gram-negative cocci, and so Neisseria meningitidis, as the name implies, a very common cause of meningitis, an important cause because it causes very severe, rapidly progressing disease. So we'll talk about Neisseria meningitidis. Neisseria gonorrhoeae, the most important cause, or the only cause of gonorrhea, which is one of the more common STDs that we have nowadays. Neisseria gonorrhoeae, I would say, is probably number one or number two as far as pathogens that are developing resistance to the point where we essentially have nothing to treat gonorrhea. And so we have exactly one drug nowadays that's reliable to treat gonorrhea, and pretty soon we might lose that drug as well. So a very important pathogen from a resistance point of view. And then Moraxella is a fairly common cause of respiratory tract infections, including pneumonia. So I don't want to forget those three because we will talk a little bit about those three in different disease state lectures. So any questions about Micro 101? I know that was a little bit rapid paced, but again, the importance really is just to start learning some of these important pathogens that you'll start to see over and over again. Start being able to recognize that staph is gram-positive, not gram-negative, etc. So other things you look for in a microbiology report, we just saw one of them, so the whole idea of 4+ Streptococcus pneumoniae growing in this patient's sputum. So that indicates that there's many, many organisms growing. And if we had a 1+, we might be a little bit more suspicious of that being a true clinically important result. There are actually some indications or some disease states. So for instance, if you have an IV catheter and we take a sample from that catheter because we think you may have a bloodstream infection, there's actually a very hard cutoff. So if you have less than 15 CFU, which is basically colonies of bacteria from that catheter tip, then that would not support the idea that you have an infection of that IV catheter. So there are some examples of that where we have very hard and fast rules for differentiating a true infection versus not. Specimen quality as well, so with pneumonia, if you just spit into a cup, does that really reflect what's going on in your lungs? Probably not. So with someone like CJ, we would have wanted his sputum to hopefully be sort of a coughing up his lung type of specimen that gives us a better idea of what's going on in his lungs as opposed to what's going on in his mouth, basically. Number of samples, and so with blood cultures often we take multiple so-called sets of blood samples separated by time, and that's because when you have bloodstream infections especially, you can have transient episodes where you have bacteremia and then bacteremia that goes away basically. And so for instance, when you brush your teeth in the morning, you become transiently bacteremic, believe it or not. It goes away and nothing happens to you, but if I took a blood culture at exactly the right moment after you brushed your teeth, I might say, oh my God, you have a bloodstream infection, but you really don't. And so for that reason, with blood cultures, we often take multiple sets, and so we compare a set that was taken maybe at 2 o'clock to one that was taken at 3 o'clock, and if the same thing is in both sets, then that's a much more concerning finding. And then also contaminants and normal flora, so you start to learn, if you go back to that picture of the person's body, and what makes sense as far as things that cause, for instance, pneumonia. Again, E. coli, not a common cause of pneumonia, so if this person's sputum was growing 4+ E. coli, you probably would start to think, well, maybe something else happened, maybe his specimen became contaminated, etc. So you start to kind of learn a little bit about what makes sense from a microbiology point of view. And then this is just for, I guess, humorous reasons, but this is a picture from my laboratory, and so we were plating a sample of an organism that completely accidentally formed this sort of heart-shaped pattern when it grew, and this is Neisseria gonorrhoeae, which makes it even somewhat more ironic that it formed that shape in the laboratory, but anyway. So getting to that question of when is a pathogen real, so certainly anything in the blood does not make sense. We don't typically have things growing in our blood, or at least we hope we don't. And so really, pretty much anything that you see in the blood is probably going to be something you're going to take very seriously and do further investigation. That said, staph epidermidis is named that way because we have staph epidermidis growing on our skin. And so if someone just took a blood sample from your vein, didn't disinfect your skin first, they're probably carrying staph epidermidis with them, with the needle, into your bloodstream. So that might be an example of something that would be more of a colonizer or a contaminant that you wouldn't truly trust is a cause of infection. But that said, most things in the blood would be taken seriously. You see here, so for instance, with the genital tract, if you see gonorrhea, that kind of makes sense. Gonorrhea causes infections there. But if you see Staphylococcus species, those are often normal colonizers, so you would kind of ignore that and not think of it as being a true pathogen from a genital specimen. And then, so going back to sort of this continuum of antibiotic therapy, and we'll talk about this definitely much more going forward, but when you've gotten your culture results back, or even when you've gotten your gram stain results back, you're moving away from that empiric phase of therapy. So with CJ right now, we could start kind of deciding to change his therapy depending on what we gave him first, because we now know that he has Streptococcus pneumoniae. So if we gave him something empirically that provided gram-negative coverage, we don't really need it anymore, right? So that gets into play as far as kind of de-escalation and other things that we'll talk a lot about, as far as you start sometimes broad with your empiric therapy, then you get your culture results back and you start streamlining your therapy and getting rid of things that you don't need to be covering, basically. So that becomes the definitive phase of therapy. And then finally, and we'll talk more about this later on too, so you've started therapy, you started CJ with a great empiric phase of therapy, so he's doing well. So maybe you started him with a fairly broad spectrum regimen that included two drugs to cover gram-negatives and gram-positives. You got your gram stain results back and you saw that he has only Streptococcus pneumoniae growing, or you know that it's gram-positive diplococci, so you assume it's Streptococcus pneumoniae. So maybe you then ditched your gram-negative drug and you kept him on the gram-positive drug, so he's doing really well. So the question becomes, do you then ignore CJ and not follow up with him at all? And so obviously you don't ignore the patients when they're on successful therapy. And so, what do we do when it comes to following up patients either during their therapy or following their therapy? As you'll learn, there are some drugs, and the two most important examples would be aminoglycosides and vancomycin, where we do monitoring of concentrations and we adjust doses based on those concentrations. So that is a really big area for pharmacists. And in most hospitals, usually pharmacists are the ones who kind of take charge of doing that therapeutic drug monitoring. So that would be one thing you'd want to do during therapy. A question often becomes, do you repeat your culture results and repeat your MIC results either midway through therapy or at the end of therapy? And that really depends on the infection. There are some infections where if someone looks to be clinically improving and they look to be cured, we want to make sure that they really are cured and they've eradicated their organism. So we might take a post-therapy culture to make sure that they've really cleared that organism. There are many infections where we don't bother to do that, however, and we just assume that the patient cleared their infection. Clinical improvement, certainly, so all of those different signs and symptoms, so fever should start to go away, white count should start to go down, really all those signs and symptoms should start to resolve if you've given good therapy. We'll talk a lot about, again, streamlining, de-escalation, which gets into the kind of rational and appropriate antibiotic use and not keeping people on very broad regimens once you know your culture results. IV to PO is a big thing, and most hospitals nowadays have formal programs, again, often involving pharmacists, where you formally evaluate patients every day to see who can transition from IV therapy to receiving oral therapy, which often is just as effective as IV therapy and a lot less expensive. And then finally, it's important to know that if someone is not doing well, there's a whole lot of work to do to figure out why is the person not improving. Did we miss an organism? Did we miss a site of infection? Et cetera, et cetera. And we'll talk about that a lot when it comes to the specific disease states. And the reason, by the way, that there's a football goal there is that when it comes to durations of therapy in infectious diseases, we don't have very many durations that have a lot of science behind them. There's some examples of that, but most of our durations of therapy are kind of, we just choose something basically. And so I knew a physician once who used to joke that we base our durations of therapy on football scores. And so people get 7 days of therapy, 10 days of therapy, and often there really isn't a rational reason why we give 7 days. It's just what we do basically. So that's one of the things I would say we lack in infectious diseases when it comes to having the basis for what we do when it comes to a duration point of view. And then finally, just one little more historical quote, I guess, about the importance of infections, just because I like these types of historical quotes, emphasizing again the kind of global importance of infectious diseases. So any questions, concerns? I typically will be trying to post my lecture slides the day before, so later tonight I should have tomorrow's lecture posted. I will also post my recordings as long as they work. So that said, someone emailed me, I forget who it was, about, okay, I don't mind if you record them as well, but I'll also post my own recordings to Blackboard as well.
Then we have a quiz.
Yes, so this week you will have a quiz on Thursday or Friday, depending on which day you're here. It'll be based really on today's lecture and tomorrow's lecture, and probably not so much on the readings. I haven't written it yet, which you can probably tell. So it'll really be based, I think, on the lectures. And I'll post a case soon. I usually try to post each week's case on Monday. This week it's just I'm a little bit behind, but I'll post a case soon to Blackboard as well. And there's a fair number of you who are going to be coming on Thursday as opposed to Friday because of the industry trip, correct? Yes? No, I think. So just make sure that if you haven't talked to me already, make sure that you speak to me so I know you're coming on Thursday as opposed to Friday. All right, thank you. Hope we get good news today from Dr. Sherwood.
Yeah.
Why, she already done?